Everyone, welcome to this ASCO GU virtual roundtable. My name is Brian Rini, and I'm a professor of medicine at Vanderbilt and Vanderbilt Ingram Cancer Center. And I appreciate being joined today by several experts in the field, and I'm going to have them introduce themselves, and we will start with Dr. Plimack.
Hi, I'm Betsy Plimack. I'm a GU medical oncologist at Fox Chase Cancer Center in Philadelphia.
And Dr. McDermott.
David McDermott. I'm a medical oncologist here in Boston at Beth Israel Deaconess Medical Center.
Thank you. And Dr. Voss.
Yeah, hi, Martin Voss. I'm a geomedical oncologist also, and I practice at Memorial Sloan Kettering Cancer Center in New York.
Great. I appreciate you all joining us, and you all have extensive expertise in kidney cancer and drug development, so it should be a fun discussion. We're going to touch on several areas in the landscape of kidney cancer, incorporating some of the data that was presented just recently at ASCO GU in San Francisco. And we'll start with frontline clear cell kidney cancer. We'll talk then about non-clear cell. We'll cover some of the other major updates, including the adjuvant setting, and then probably end with, sort of what you're most excited about, as we head into the future and to the main ASCO meeting. So why don't we start with frontline clear cell kidney cancer? There were a few updates at ASCO GU. There was, I believe, an 8-year Ipi/Nivo update, sort of impressively long data. There was a approximately, I think, 4 or 5-year update of the Cabo-Nivo data, and then some subset data from Len-Pembro that was presented. So Betsy, I'll call on you first, if you don't mind. We've talked a lot in this and many other settings about frontline kidney cancer and IO-TKI versus IO-IO, but maybe if you could just think about if the recent data impacted you, how it impacted you, and sort of where are you in early 2024 in that debate and in your practice?
Yeah, thanks for the question. So I still find it a fascinating topic, frontline. I know we've seen now the data multiple times and we're just watching long-term follow-up, but that is so critical to see how patients do long-term, because we design these studies thinking that all patients would ultimately progress and pass away on these studies, and they're not yet. With Ipi/Nivo at 8 years, we're still seeing folks surviving, some not even progressed yet. And it looks like the other TKIO combos are going to follow suit based on where we are now at the 4 and 5-year follow-ups for these studies. So I'm excited about the data. I think every time a fresh cut comes out, I try to challenge my assumptions and my practice to see if anything changes. I will say so far, no changes to the way I approach, which is Len-Pembro for poor and intermediate risk, and Axi-Pembro for good risk. Again, looking for that early response rate so patients can be durable responders. I do want to see in the future, and this is a shout out to David because he's done this analysis for Ipi/Nivo, but treatment-free survival for the TKI-IO combos. Because the one drawback that we hear from clinicians about those combos is that we can never stop therapy. I'm not sure that's true, but we have to ask the question.
So just maybe to summarize, updates are good, right? We always want to see long-term data, and patients want to know, right, doc, what's going to happen to me over time, and they don't just want 1-year data; they want multi-year data appropriately. Nothing necessarily in the data presented at ASCO GU. It sounds like that impacted your practice. Is that correct?
Correct.
Okay.
Yeah.
I guess maybe the question is, what kind of data would impact that practice for you? I mean, it doesn't seem like the Ipi/Nivo data is going to change, right? It's been remarkably consistent, I guess, now for 8 years. So probably year 9 and 10 won't bring us a whole lot of changes. But is there something in for future data where you'd say, boy, now I'm gonna do something different?
Yeah, I mean, I think what I'd like to see in future data, what would change my practice, is really patients who we are curing, meaning they die of something other than kidney cancer. And we never thought we'd have the opportunity to explore this. We have assumed that deaths on any clinical trial are deaths from the cancer that we're studying. But I think that might not be true for Ipi/Nivo. And so while we have these overall survival curves, the question is, some patients out 8+ years will pass away. If that's happening and they're dying of other causes, that's a win, not a loss. And if we could look at that and really see that that's happening, that could change my practice. I would also need to know that that's not true for the TKI-IO combos. That would need to be shown also, and those studies are quite a bit further behind in doing that, because we do sacrifice that upfront response rate with Ipi/Nivo over a TKI-IO. So I think there are opportunities for very long-term data cuts if we look at the right things. to actually inform and change how we practice now.
And I don't think you all can correct me if I'm wrong. I don't think we've seen such data about, I don't know, non-renal cancer deaths in any sort of granular form. I think I've seen some disease-specific survival curves somewhere. I can't quite remember, but I'm not sure we've seen that sort of granular data, correct?
Not yet, and we should
Not yet.
keep asking for it. Yeah.